Well, you're very welcome to today's talk, Wednesday, the 10th of April. Now, truths which are undeniable are starting to come out sort of drip by drip. I don't know whether this is some sort of strategy, but it's happening around the world. The example we're looking at today is from Australia, but the numbers can be extrapolated, in my view, to the United Kingdom, to the United States, to Canada, to wherever you are in the world. And it's related to long COVID and other causes of long COVID type syndromes. But stick around and we'll just be saying what's in the paper. Now, the implications for this are huge, by the way. Let's just have a look at this briefly. This is the paper here. Long COVID sufferers can take heart. And this is from the Australian Journal of General Practitioners. You could be forgiven if you've never heard of that journal. It's not a common journal. Things just seem to be sort of trickling out gradually. Sort of bit at a time. Anyway, let's go on to the information we have. Sufferers can take heart. Very strange title, not what I would have called it, because this is basically a bad newspaper as far as I can see. Australian Journal of General Practitioners. Now, studies have shown an increased risk of myocarditis after vaccination with mRNA encoding SARS coronavirus 2 spike protein. This is well known already, but it does reiterate it. Good to see this in the sort of more official literature. mRNA vaccines can result in spike protein expression in, and this is from the article, muscle tissue, and it doesn't say where, but presumably all around the world, lymphatic system, all around the body rather, well, all around, in people's bodies all around the world, in muscle tissue, lymphatic system, and the lymphatic system, of course, is all over the body. Your tonsils, your appendix, thymus, spleen, but all over, under your armpits and your groin. There's lymph nodes. It's all over the body. In your thumb, there's untold numbers of lymphatic vessels all over the body. So very, very systemic manifestation. Lymphatic system. Cardiomyocytes. These are specifically the cells in the myocardium of the heart. And these can, mRNA vaccine can result in spike protein expression in cardiac myocytes. This is very, very bad news indeed. Other cells enter into the circulation and basically can go anywhere. And we've looked at literature various times on this channel pointing out that this goes into places where you really wouldn't want the spike protein coding mRNA to go, to put it mildly. There is concern that COVID vaccination per se might contribute to long COVID. Well, there we have it. This is an official medical journal, and they're now saying there is a concern. You see what I mean? They're kind of letting it out drip by drip, I think, that COVID-19 vaccination per se might contribute to long COVID. Let me know what you think. I would have thought that's a debate that's done and dusted a long time ago, but good to see that that is in the official literature. They go on, and again, we've given the reference for that there, giving rise to the colloquial term Long Vax. I put the reference there for it, but we did think of that a long time ago, as did many others, because it's such a self-evident description of this syndrome that we are seeing, unfortunately. The spike protein of SARS coronavirus 2 exhibits pathogenic characteristics and is a possible cause of post-acute sequelae. Again, this is from the official paper, so it's quite powerful, really, not because of what it says. We've suspected this for a long time, but it's in this General Practitioner's Journal now. Spike protein SARS coronavirus 2 exhibits pathogenic, that's disease-causing, characteristics and is a possible cause of post-acute sequelae. In other words, ongoing complications after SARS coronavirus 2 injection or COVID infection or COVID-19 vaccination. And I agree with this. These sequelae, these long-term complications, and I saw patients with this just last week when I was allowed to go to a clinic. We saw these patients, and it can be difficult to tell the difference between post-COVID infection and post-COVID vaccine syndromes. But it's good to acknowledge that both are possible causes of this pathology. COVID-19 vaccines utilise a modified stabilised perfusion spike protein that might share similar toxic effects with its viral counterparts. Toxic effects of the spike protein induced by vaccination, again, being slipped into the text there. Now, what they're talking about here is that the uridine is one of the bases, and it's the one in the vaccine is not the natural uridine. Now, they say it's utilise a modified stabilised perfusion spike protein. In other words, that sounds better than saying it's an unnatural RNA base, which it is. It's one that's been chemically altered. So, of course, this is one of the Uracil is one of the 4 nucleotide bases: adenine, cytosine, guanine. Now, the critical contribution of pseudo-uridine to mRNA COVID-19 vaccines is dealt with in this paper. So this is a pseudo-uridine. It's a pseudo-RNA. It's not the body's natural RNA. That's the key point. This is not the body's. It's not copying the body's natural RNA. It's changed it. And again, they tend to wrap this up in scientific language. Both consisted of the N1 methyl pseudo-uridine modified messenger RNA encoding for SARS coronavirus 2 spike protein, and were delivered with a lipid nanoparticle formulation. Again, no natural counterpart. Man-made, synthesized things being introduced into the body. Right, the article goes on. A possible association between COVID-19 vaccination and the incidence of POTS has been demonstrated in a cohort of 284,592 COVID-19 vaccinated individuals. So this thing, POTS, has been seen in people who've had the COVID vaccines. And just a reminder, the NHS definition, postural tachycardic syndrome. POTS is when your heart rate increases very quickly after getting up, sitting down or lying down. And when the patients get up, they can feel absolutely awful. I've talked to quite a few of these patients, and they get tachycardia, palpitations, dizziness, even fainting. Horrible syndrome. And it's now being admitted it can be a post-vaccine complication. We've known it for a while, but again, good to see it admitted to. Recipients of 2 or more injections of the mRNA vaccines display a class switch to immunoglobulin type 4 antibodies. Now, we've looked at these before. These will reduce the immune response. So it's an example where giving vaccines will reduce immunity. Go figure why we would want to do that. I suppose someone's making money out of it, but I'm not quite sure why you would want to reduce immunity with vaccination. But abnormal high levels of IgG4, immunoglobulin G4, the type, produced normally after about a week or 2 weeks after exposure. Now, this is dilated from this article, might cause autoimmune disease. Disease is dis-ease. So you are not at ease, abnormal, a state of abnormal ease, dis-ease. Promote cancer growth. And again, this is just being trickled out in this article, promote cancer growth. That's what they say, it can promote cancer growth. They don't actually say it can cause cancer, but it can promote the growth of it there. But of course, we all probably get cancer quite regularly. It's just the immune system suppresses it. But if the immune system can't suppress it, then the cancer is not suppressed. Another thing they include specifically is autoimmune myocarditis, the body's immune system attacking its own myocardium. And of course, the reason you're able to watch this video is because your myocardium is contracting, your heart is pumping, and that's perfusing your brain with blood. If the myocardium doesn't do that, then you wouldn't be watching this video, shall we say. But again, now admitted in this article. Other IgG4 related disease. So other things, it doesn't specify, but they're the ones it mentions, right? So they mention the autoimmune disease, promote cancer growth, and autoimmune myocarditis are the ones they mention, but other ones as well. There are clear implications for vaccine boosters where these and similar observations relating to COVID vaccine and the incidence of long COVID symptoms are substantiated. So if people are getting autoimmune disease, promoting cancer and autoimmune myocarditis after vaccine. The article here is saying there are implications for vaccine boosting. Yeah, I think there are. Let's just say I won't be getting one. There are indeed implications, and implications on a massive international scale as well. Yes, there are implications. Right, adding further to public health officers' concerns. I suspect, now that the evidence is coming out, there's a few concerned people around the world. Many concerned people around the world. Now, will this come out into the mainstream? We don't yet know. Some scandals take years or decades to come out. Will I see it come out fully in my lifetime? We simply don't know yet. But these things are starting to make it look more positive, that self-evident truths will become known to more and more people. So this is very encouraging, I believe. Right. Understand the persistence of viral messenger RNA and viral protein and their cellular pathological effects after vaccination with and without infection is clearly required. So in other words, we need to do research looking at the disease-causing effects of viral protein, even if the person hasn't had the infection, just from the vaccine. Again, good to see that there's specifically mentioned here that we need research specifically into the effects of the spike protein produced by the vaccine specifically. And we can do antigen tests for that if we want to, differentiating between the antigens of the virus and the vaccine, and certainly the antibodies of the natural infection and the vaccine are different, as we've looked at before. Because COVID vaccines were approved without, this is quite good, this. Not good, it's terrible, but it's revealing truths. Because COVID vaccines were approved without long-term safety data and might cause immune dysfunction. Yep, they might cause immune dysfunction indeed. In fact, I believe we've seen it numerous times. But again, admitting now the vaccines were approved without long-term safety data, despite the assurances that we were given. This is why I'm so cross. We were given these assurances. We were naive enough to believe it, and it's turned out to be 180 degrees the opposite of what we were told. The end of that age of deference for sure. But don't get mad, stick to the facts. Right. It is perhaps premature to assume that past SARS coronavirus 2 infection is the sole common factor in long COVID. In other words, we have to consider vaccination as the cause of a proportion of these cases of long COVID. Not necessarily the majority, but a proportion. Millions worldwide experience post-acute sequelae of COVID-19 or post-vaccine. This is millions of people around the world. Although the Australian Bureau of Statistics and other health agencies in Australia do not survey the prevalence of long COVID, it is estimated that it affects hundreds of thousands. Now, bear in mind the population of Australia is only, I think it's 40 million, something like that. In fact, no, I can't. Anyway, it's not that many. No, it's not even that. It's I can't remember. Apologies to Australians. I've just been there as well. My apologies. But relatively small population compared to the UK or the United States. Multiply this by the population ratios, of course, and it becomes a horrendous global problem that's unfolding. Long COVID is a heterogeneous disease, so many sort of possible manifestations with variable cardiac, heart, pulmonary, lung, blood, hematological and neurological involvement. What have we done? There is no consensus on what causes lingering COVID-19 symptoms long after the acute infection has cleared or the acute vaccine has cleared. So there's not a consensus. We need more work on this, although we have got some pretty good ideas. Often unable to secure a diagnosis, patients are wont to seek multiple serial medical opinions, frequently being told their condition is due to anxiety or post-pandemic mental issues. So I've talked to so many people. Doctors have said, no, it's in your head. Basically, you're a bit of a head case. It's anxiety or post-pandemic mental issues. Is this a new syndrome that they're talking about here? Let's hope not. The median duration of long COVID symptoms is 5 months, but 10% of patients still experience symptoms at 12 months. Of course, 10% of all those that are vaccinated is a massive number. Fatigue, shortness of breath, difficulty concentrating are reported at least up to 2 years after SARS coronavirus 2 infection. So at least up to 2 years. And we've seen long vaccines ongoing for some years now, of course. It's still too early to say whether some individuals with long COVID might ever recover. Are these patients that are suffering long vaccine and long COVID, a proportion of them, are they ever going to get better? The answer is we don't know, because we haven't really tried that hard. And that's a problem. Long COVID patients present elevated inflammatory biomarkers. Now, this should be tested for more often. So one's called interleukin-6, an inflammatory cytokine. C-reactive protein is an inflammatory marker, and tumour necrosing factor alpha is another inflammatory cytokine. These could be tested for, because we know these are elevated in these long-term inflammatory conditions. So we need to test for them as a diagnosis, not just say it's anxiety. The worst mistake you can make in psychiatry, as we've said hundreds of times, is assuming that something is psychological or psychogenic when it's got a biological cause. Only assume something is psychological when you've excluded biological causes. It's a fundamental axiom in psychiatry. Long COVID digital support groups report months of frustration at not being listened to, these patients say, finding the health system woefully inadequate with few primary or secondary care professionals knowing enough to offer much. Well, we need training programs from people like Professor Clancy in Australia, who's got some pretty good ideas in this, and other medics around the world. The outcome for some of those experiencing long COVID is self-prescribed medication. I mean, we really don't want self-prescribed medication. Patients aren't the experts. Supposed to have healthcare professionals for that. Using over-the-counter remedies, which of course can be harmful. Dietary changes based on potentially conflicting or misleading online information. We need doctors to be prescribing these treatments based on sound evidence. And it may well be, who knows, it may well be that the best treatments are very inexpensive, very safe, very non-toxic, remarkably cheap from established, well-known, repurposed drugs, which are perhaps prescribed 250 million times a year to various people around the world and have had over 3 billion human prescriptions. Who knows? It might turn out to be something like that rather than something that costs $1,000 a pop. Who knows? We need the research to find that out. And we need the freedom to do the research to find that out. Freedom to do research would be a good idea. Let me know if you think we have it. Some speak of a substantially proportion of their income being used in this way. I've met people financially ruined by this. It's totally, utterly tragic, because the people desperately trying to get themselves and their loved ones better from conditions that often aren't even acknowledged. A few people have made a few billion out of this recent pandemic. Maybe they'd like to chip in and help these people. Who knows? Don't hold your breath. In Australia, an estimated nearly 250,000 of those with long COVID are no longer in full-time work. And work absenteeism might significantly impact a nation's economy, as in the UK, which we've looked at recently. Huge number of people on the sick. In the US, long COVID has been declared a national emergency. So we're talking about a national emergency through long COVID and post-vaccine syndromes. Reduced to working part-time to cope with unwellness, those with long COVID commonly report having to wait a year or more before receiving a diagnosis. So unfortunately, we're dealing with a global problem of huge proportions. And the truth is starting to trickle out, but not enough and not fast enough, and not enough money is being put into working out what the best treatments and approaches are. But really, before we can do that, we need admission of what the problem is. In healthcare, we assess. And my assessment is we've got a heck of a problem. Only then can we effectively plan, implement and evaluate the effectiveness of our intervention. So check out the paper yourself, eminently readable, not in medical jargonese, all pretty clear stuff. But as we say, from the Australian Journal of General Practitioners. So a trickle of truth starting to come out. Let's hope it becomes a flood. And for now, thank you for watching.